I'm going to spend about 20 minutes talking about where we are currently in the field of lupus treatments and why it's not good enough. So let's talk about what has happened in the last 5 years in specific areas of lupus management that you're all familiar with. We'll talk about what's new with non-steroidals, antimalarials, corticosteroids, topical therapies, immune suppressive regimens, biologic therapies, and conclude with the need for new drugs in lupus. Most of us don't realize that there have been some incremental advances in the last 5 years. For example, approximately 80% of all patients with SLE are taking over-the-counter or prescription non-steroidal anti-inflammatory drugs such as ibuprofen or Advil or Aleve. And they do so for low-grade fevers, headaches, arthralgias, muscle aches, pleurisy or chest pains, and 80% use it intermittently, 20% daily. But the problem is that none of these agents are DMARDs. They're not disease-modifying. And their use is limited by kidney, liver, and GI toxicity. So what's new in the last 5 years? What's new are that now we can have some of these available as a schmear or topically. And the main one that's used in the United States and internationally is diclofenac or Voltaren gel, and there's also compounded ketoprofen gel. The reason why I mention this is that they're applied every 6 hours. They are extremely non-toxic because no more than 6% gets systemically absorbed. And in fact, in the last 5 years since it became approved by the FDA, topical non-steroidals are the first line of choice for rheumatologists and orthopedists in managing hand osteoarthritis. In the 2018 EULAR, or European Recommendations for the Management of Hand Arthritis, it says topical treatments are preferred over systemic treatments because of safety reasons. Topical NSAIDs are the first pharmacologic topical treatment of choice. And a significant minority of lupus patients have osteoarthritis, and many of them have relief from their inflammation when they use these agents. You have to use them like every 6 hours sometimes. Just using it occasionally may not be enough. But there are no reports of lupus patients having adverse reactions to topical NSAIDs. Let's move on to antimalarials. How many patients here are taking antimalarials? How many lupus patients in this audience are not taking antimalarials? Only a handful. These are very, very useful drugs. We've heard several presentations and posters on this at this meeting. But what's happened in the last 5 years? What's happened is that we can now measure drug levels, and we can tell if the patient is compliant or adherent with taking the drug. Because if you don't take the drug, it won't work. And patients who are inconsistent with taking the drug have more damage and more flare rates, and this has been documented very, very recently. Why should lupus patients of all types, organ-threatening and non-organ-threatening, take or be started on antimalarials? It's because it reduces flares, organ damage, lowers lipid levels, reduces risk of clotting, and it makes some drugs, such as mycophenolate, more effective, and it improves survival. And now we have newer tools to pick up eye damage very early. The OCT, or optical coherence tomography, or multifocal electroretinograms, which can be done in an office setting by your ophthalmologist, can pick up early retinopathy, which was not possible 5 years ago. Although it is, there have been some debate, the American Academy of Ophthalmologic Surgery recently came out in the last 5 years with recommendations on screening for hydroxychloroquine or Plaquenil retinopathy. And that's because if you are on the drug in a recommended dose, which is 5 mg per kilogram real weight, the risk of toxicity is less than 1%. At 10 years, it's still less than 2%. But by the time 20 years have elapsed, it goes up to almost 20%. Patients should have a baseline fundus exam to rule out anything pre-existing and be screened after at least 5 years, and their acceptable doses monitored with the OCT or other visual fields. Because you only have one set of eyes, it's not reversible, and it's really important that we track how much one is taking. What is new in cutaneous lupus? Well, cutaneous lupus can scar and lead to permanent hair loss and disfigurement. And so we do have some new treatments for this. One is there are some newer ultra-high potency and low potency topical steroids that have come on the market. Secondly, there are non-steroid anti-inflammatory topicals such as tacrolimus or Elidel, which have now become generic, so the prices become more accessible. Tacrolimus or penecrolimus is Protopic or Elidel, and they don't scar, they don't thin out the skin to the extent that some of the fluorinated topical steroids do. We're using very small 27-gauge needles to inject steroids directly into cutaneous lesions. And Antimalarials have been used historically in combination to treat this, as well as immune suppressives. But what's new? What's new are the novel agents. There are two approaches which are novel. One is there's a drug called tofacitinib, which is what we call a JAK inhibitor, which is on the market already for rheumatoid arthritis. It's also approved for psoriasis, Crohn's disease, and some dermatologists are using it for alopecia, mucocutaneous ulcerations. It's also approved for Crohn's disease. However, there is nothing to stop, and it's perfectly legal, to get tofacitinib produced by a compounding pharmacist as an ointment. And this is now the study of 5 controlled trials for use in hair loss and regrowth of eyelashes. One can also use oral tofacitinib, but that's more toxic and it has to be used carefully. But many dermatologists have availability from compounding pharmacists to use the topical ointment. There's also a big effort in the field of dermatology to use platelet-rich plasma. There have now been 5 double-blind, placebo-controlled trials for scarring alopecia with positive results in 4 of them. So there are some developments. What's new with immune suppressives? Immune suppressives are areas that not only kill bad cells, but unfortunately they also kill some good cells. They are not specific. They include methotrexate, mycophenolate or Cellcept. They include azathioprine or Imuran. And they also include a drug called leflunomide or Areva, which has been on the market since the early 90s for rheumatoid arthritis. There are 2 or 3 lupus trials that suggest it has some modest benefits for lupus arthritis, but what's new is that in 2010, it got approved by the Chinese version of the FDA for lupus in the kidney, but in a dose much higher than we use in the United States, which is 10 to 20, in a dose of 40 milligrams a day. Is there anything new with corticosteroids? Well, there's 3 things that are new. One is the release of a drug called Rayos, which stands for timed-release prednisone, and that's based on the assumption that interleukin-6 is responsible for much of the damage in systemic lupus or in rheumatoid arthritis and polymyalgia rheumatica. Most interleukin-6 is released between 2 and 6 a.m. So in order to target this, one takes a tablet at 10 p.m., and then when it starts to work at 2 a.m., because it has to leach through a double matrix, most of the drug is released between 2 and 6 a.m. There is a lupus clinical trial network called LUCIN, which is currently underwriting, as part of its repurposing effort, a trial with Rayos for lupus, with its primary outcome being improvement in fatigue. All 60 patients have been enrolled in this study, and it's a 3-month trial, and hopefully we'll have some results by the end of this year. The second agent is there is a drug called Acthar, which a precursor of corticosteroid is ACTH in the adrenal gland, which stimulates the release of corticosteroids. It works similarly to corticosteroids, but it also has a unique mechanism of action in dealing with the melanocorticoid system, melanin. And whether this is important in lupus is not certain, but nevertheless, there is an ongoing clinical trial to see if this very expensive agent is worthwhile. And finally, several of our pharmaceutical colleagues are working on trying to figure out why some patients, 1 milligrams of prednisone has the same effect as 5 milligrams, and everybody seems to have different receptors and metabolism of steroids. So there are certain selective glucocorticosteroid agents that are being looked at in phase 2 trials. What's new with calcineurins? What is a calcineurin? Calcineurins are agents that have historically been used to treat lupus in the kidney, and they prevent patients with organ transplant from rejecting them. It includes cyclosporin, tacrolimus, or Prograf, and rapamycin. And these drugs, tacrolimus in particular, is now being used more and more for lupus nephritis. There are studies suggesting that that compared to cyclophosphamide or mycophenolate, at least for the first 6 months, but not longer, it may be equal. And now there's some efforts to add it on to azathioprine or mycophenolate. What's interesting about this family of drugs is it appears to be safe in pregnancy. There was a study published last year suggesting combining it with corticosteroids and CellCept from Hong Kong and in China, suggesting that combinations of tacrolimus with mycophenolate or cyclophosphamide is synergistic. So there are some incremental improvements. It's hard to believe, but belimumab was approved in 2011. It's now 8 years later. And we now know from long-term follow-up of the original studies that this drug has legs, and people are still taking it 8, 9, 10 years later, which is much better adherence than almost anything, including Antimalarials. And some interesting work that was published last year suggest that the drug is indeed steroid sparing by at least 20%, and that one lupus patient in 7 during this period was able to totally discontinue corticosteroids. And now we know from following patients up to now 13 years that if we look at certain accepted markers of lupus damage, that it does prevent progression of the disease compared to those who did receive standard of care but not belimumab. And about 1.5 years ago was heralding the introduction of subcutaneous belimumab, where one could more easily give it as a shot once a week. I think the number of people taking belimumab in the last 18 months has trebled in the United States. This agent is equivalent to the intravenous form. Some people like the intravenous, some people like the subcutaneous, but this is certainly simple, very, very safe, and effective. We talk about the concept of repurposing. Repurposing means taking a drug that's already on the market and trying for a disease that it's not approved for, and some are listed here. We know that rituximab, which is approved for rheumatoid arthritis and approved for many other hematologic disorders, as well as pemphigoid in the last year, has failed in several poorly designed trials to reach its primary outcome measures. But now we know, following patients for 5-10 years, that certain lupus subsets, such as those with inflammatory arthritis, central nervous system disease, polyinflammation of many nerves, vasculitis, and low counts, do appear to benefit from rituximab. Abatacept or Orencia is another rheumatoid arthritis drug that has not achieved its primary outcome in several lupus trials of various quality design, but it does appear in just about most of these trials if one has an inflammatory arthritis to improve it. Also, there are drugs on the market for rheumatoid arthritis as well as vasculitis that block a cytokine known as interleukin-6, and some of these are known as Actemra or Kevzara. There are a few publications of agents using anti-IL-6 drugs in lupus, one from the NIH that appears to improve joint and skin disease, although in a couple of the trials it has not met its primary outcome. It has, with certain lupus phenotypes, met secondary outcomes, appears to be generally very well tolerated, and for our patients with lupus who maybe have a rheumatoid overlap or rheumatoid factor, it's sometimes used or used in other specific circumstances. We all have seen a lot of advertisements on television for anti-tumor necrosis factors, for rheumatoid arthritis, psoriasis, and other conditions, inflammatory bowel disease with etanercept or Enbrel, infliximab or Remicade, adalimumab or Humira. And there are some evidence that it does improve lupus arthritis, but the studies that have been published show that it's short-lived and relatively disappointing. And finally, we have the new small oral agents that are on the market, which is baricitinib and Xeljanz. And these are approved for rheumatoid arthritis, and Xeljanz I also mentioned as tofacitinib as a topical. But there is a study going on at the NIH for tofacitinib in lupus. And there also, you heard earlier today, a presentation of a phase 2 trial of baricitinib for lupus that is very promising and now going into a phase 3 trial. So why is these treatments not good enough? Well, despite improving survival rates, lupus has a higher than expected mortality rate that has not significantly changed since 1980. with the development of steroids, dialysis, improved antibiotics, improved antihypertensive agents, and we still, in the 1960s, had cyclophosphamide, methotrexate, azathioprine, hydroxychloroquine, and prednisone. So we have not made a huge difference. The risk of myocardial infarction is 50 times greater in women in their last 10 years of their reproductive years. Accelerated atherogenesis, heart attacks, is attacking younger women. And there was a study published a few months ago that the second most common cause of women in their 20s dying in the United States is lupus. Lupus is associated with more emergency room visits and hospitalizations. When a lupus patient goes to the emergency room for chest pain, it could be their lungs, it could be pleurisy, it could be an effusion, it could be an infection, it could be a pulmonary embolus, it could be pulmonary hypertension, it could be the chest wall or costochondritis, it could be pericarditis, it could be microvascular angina, and it could be a heart attack or arteritis of the coronary arteries. And most people in emergency rooms just send these people out with opiates and really doesn't get to the underlying problem. And up to a third of all lupus patients are disabled within 5 years, and more than half at 10 years. Work loss is a common consequence of lupus. It decreases stamina and endurance, and a lot of the reasons are for musculoskeletal, neuropsychiatric, or thrombotic complications. This leads to loss of socialization skills, personal isolation, loss of self-esteem, and it's a huge, huge problem. And even if the SED rate and CRP and the DNA and complement aren't that bad, or they show mild disease, studies have shown that damage still accrues. In other words, 40% of lupus patients have an increase in their damage index to tissue after 3 years of follow-up. And a third of patients accrue organ damage within 5 years. And, as I mentioned, even with very low smoldering activity. So we have our work cut out for us. The progression to end-stage renal disease or needing dialysis has not decreased since 1980. And even though certain ethnic and racial groups and certain those with literacy and educational attainment do better than others, in each group, the progression to end-stage renal disease has not decreased over time. So, despite new advances and improvements in our understanding of lupus therapies, existing regimens are still associated with poor quality of life, shortened lifespans, and suboptimal treatment. So new treatments are needed.